Well, hello and welcome back to Go With Us to EULAR 2021. We are officially at the Scientific Congress for EULAR, who recently changed their name. They are now the European Alliance of Associations for Rheumatology. And we go our organization, which is International Foundation for Autoimmune, Autoinflammatory Arthritis, or AiArthritis for short, we attend the two major scientific conventions every year, which would be EULAR, which usually happens in the June months. Yeah. And then we attend the American College of Rheumatology that is somewhere in the United States, usually in November of every year. And some of the research ties together. Some of it is very separate, very different, but we always stay in the know. And who is we? Who are we? I said, is we? That sounded terrible. We're tired. We're sorry. My pink face, we're flaring a little bit too. Yeah. So I am Tiffany Westridge Robertson. I am the CEO of the organization, but I'm also a person living with diseases like everyone who is affiliated with being thought leaders in our organization. I have axial spondyloarthritis, the non-radiographic version, and I am here with two smiling faces next to me. Katie, why don't you say hello?
Well, hello. My name is Katie Simon. I'm from Metro Detroit. I am the Senior Program and Communications Manager at AiArthritis, and I've been living with rheumatoid arthritis for over 19 years now. Awesome. And this is my first EULAR conference, so lots to learn, and I'm very excited for it.
Good. And Miss Deb.
Hey everybody, I'm Deb Constein. I am in the Sun Prairie, Wisconsin area, so right around Madison. And I too have been diagnosed with rheumatoid arthritis, and I was diagnosed at the age of 13. So 38, 39 years. I'm not doing my math right now in my head.
That's all right.
Yes. So again, Tiffany and we've actually been roomies while we've gone to these conferences, and we've been attending these last 2 years virtually. So it's been a lot of fun.
Yes. So what we do at our organization, our mission is to help others like us to be able to have a voice. We believe all voices count, all voices, because we all have different journeys, different perspectives, different opinions. So we don't want to always be facilitating the opinions we think everybody has. So that's a little different with our organization. We don't necessarily even call ourselves patient advocates, because we're more facilitators to be able to champion all of the voices and have them all present. So in saying that, in addition to bringing them to the table, then the goal is to work alongside other stakeholders as equals, not as advisors, as equals. So these conversations we have together, we can identify these gaps and problems that we have to solve, and then we work together to solve them. So that is sort of our unique way that we have a mission here at our organization. And in saying that, we don't want to be the only ones going to the scientific conferences either. But we do have a lot of experience, and that experience can help other people living with our diseases sort of navigate if they wanted to go, or better understand and translate the information they're learning, because
layman's terms.
We can help with that as well. So we started this program called Go With Us to conferences. It's a pilot program as of 2021, and we've been doing it now for about a year. And we'll do this again at the ACR. So if you are a person living with these diseases and you think, wow, I want to be part of that, then let us know. Shoot Katie an email. Katie, Katie at AiArthritis.org, and in the subject line, put Go With Us conferences, and she'll know what that is. So these are our debriefs. One of the things that we do well is talk. So we find the best way to relay the information that we find at these is to speak about it, because again, in order to solve problems or really go, ooh, a light bulb moment happens when you're talking. It happens. So instead of just feeding out bullet points in words, via, an email, etc., which are also very beneficial. We just have a different style. And this is more conducive to what we do as our mission. We're going to give you really an overview of treatments. So things that we've seen at this conference that are up and coming treatments, research on certain diseases where they've been testing treatments for efficacy, and then a little bit on comorbidity, because we really thought that ties in well together, because as we deal with treatments, one of the themes that's come up in our other debriefs is this, I'm having a mind blank here, polypharmacy.
Yeah,
Can somebody reiterate what that was for those who haven't tuned in previously?
Pharmacy was basically people being on at least 5 to 6 medications. Is that right, Katie?
It actually
I was trying to think.
It ran.
There was, sorry. There was a term that.
Go ahead.
I'm sorry. There was a term that described someone being treated with multiple drugs for one particular condition. But then it was also something as far as being treated with many drugs, and that was like another definition. So I was trying to remember which was which.
Eileen, shout out, because it's not just us, the three of us that are going to EULAR. We are kind of the core team, and then we brought along 3 other people living with the diseases. So shout out to Patrice, volunteer with us for a while, went with us last year, and she's a repeat going with us person. And then we also brought Leslie, who is from Getting Closer to Myself blog, and Eileen Davidson, who is, you might know, is Chronic Eileen. So they are also attending with us and joining on some of these debriefs. So in saying that, Eileen, so now you know who I'm talking about, did a little bit of background and said that on some of the places they mentioned it is 5 different drugs, and then other definitions range between 2 and 11. So there's not really a specific, it's just really multiple, I think we can all agree on. And something that also came out in one of our other debriefs was that they are not talking about biologics. They're talking about the comorbidities you have treating your own disease in addition to the biologics. So if you have high blood pressure or diabetes or things like that. So so as we're talking about comorbidities, which is a theme emerging here at EULAR 2021, we thought if we're going to talk about treatments, it would be good to sort of end with a little bit more, because Deb's been seeing that. So I am going to actually walk through bullet point sort of form on some of the highlights of the treatments, and then I'm going to ask my lovely co-leaders here to sort of jump in, because I don't want to be the only one talking.
Sounds perfect.
Okay. All right. So the first thing is, we're seeing a lot of psoriatic arthritis, a lot of lupus. Now, we've been seeing, been seeing lupus for a while, right?
Yeah.
Deb, it's
good handful. I mean, there's been a healthy handful of lupus sessions each time we go, but I think this year there's been even more.
I'm wondering too if it's because lupus nephritis, which is a very severe form of people living with the systemic lupus. There's different types of lupus. So this is a severe phase that you can develop. And I know the first treatment for lupus nephritis in the United States anyway came out this year. So there's just a lot that's going on in that. So that's great. One of the things that we've talked about before is some of our patient community gets upset about everything being on RA. Yeah. And one of the things just to understand about that is when researchers are trying to study something, one of the reasons that they pull RA first, I want to stress that first, is because it tends to be one of the easier diseases to study. There are endpoints that have been developed. There are baselines that have been developed, whereas you have a disease like lupus, for example, there's a lot more comorbidity. There can be a lot more organ involvement that's happened even early on. So that's why it seems like everything's RA, but it's just that that's a starting point in a lot of places, and it can be adapted to other diseases easier, and that's why you see that. So
I feel like I'm almost apologizing because I have the disease, but I feel like I almost am apologizing that everything is on RA because, you know, it is a main focus. And I feel bad for those that have other diseases too.
well, I'm hoping that explanation helps a little bit.
Yeah, it absolutely did. That was a really good explanation.
It's not that it's intentionally leaving other people out. It's that it's just the easiest to move out. But in saying that, it is also a very big focus, as we've talked about in debrief number 3. If you want to go back, it is about this movement towards precision medicine and the recognition that our diseases, even RA, which we saw, I can't remember if it was EULAR2020 or ACR 2020 in the guidance, but that they're recognizing our diseases have individual needs and are complex. That was the word, complex. They said psoriatic arthritis.
I believe it was ACR.
I think it was too, now that I'm saying that.
Yeah.
And we were like, yes, we are complex. Woo! So we were excited that it was recognized, and you know, it wasn't to some of the other diseases that are often labeled individualized and complex, but it was kind of that trickle down. So there's it's happening in both categories there. So anyway, let's give a little bit of just a very quick bullet pointed rundown here. So lupus, as we were just talking about, there was a small trial, and when we say small trial, it was around 50 people, and so, you know, you take that with a grain of salt. But what I also read by some of the rheumatologists that published other information on lupus is that this isn't the first time that this has happened, the study. And what that is mixing or blending, even though it's not, I guess, necessarily polypharma because it's biologic. So I don't know what the category what it falls under. Yeah. But it was first treating lupus with 2 infusions of Rituxan, followed by Benlysta. And even though only 32 completed the trial, which was about a year long, there was significant improvement compared to the placebo. So that's very promising news, you know, for lupus patients, because historically you have, you know, steroids is a very first step and trying to get things under control. And with the complexity of the disease and testing the double treatments, I'm just curious, as people living with the diseases, what are your thoughts about, you know, if you were presented with an opportunity to say, well, let's try 2 treatments instead of 1, what would your thoughts be?
Hey, I'd
sure.
Yeah.
There was no hesitation. Come on. Yeah. Well, because as we know, some patients are you know, we have other things. Well, we do have comorbidities. I think that we have to, you know, think about that as well. Like, is there going to be a safety problem with some of the other medications I'm on, which polypharmacy would come in? I'm on board with you too. I actually just went to see Al, rheumatologist, Dr. Al Kim. He is on our talk show quite often. Started a program called Roomy Rounds with me, and I went to see Al, shout out, on Monday, and about my disease, and he had actually said, if we can't get it under control with just the Cosentyx that I'm on right now, but it's still new, it's only 3 months, that we might have to add another treatment, to a small dose to it. So I was like, okay. I didn't blink an eye either. I mean, I'm, you know, whatever's gonna help me get this under control. And then again, we keep saying there were a lot for psoriatic arthritis. That in the past, the last few years, axial spondyloarthritis, my diagnosis has been the hot topic. And for those of you might be more familiar with the term ankylosing spondylitis, but that is being phased out, and the umbrella term is now axial spondyloarthritis, with ankylosing spondylitis essentially suggesting that you have radiographic damage non-radiographic, I think, speaks for itself. there's no damage. There's nothing showing on the radiographic evidence. So that's the difference. Anyway, there were several things on psoriatic arthritis, and there was one presented by Dr. Philip Mease, and I'll do another shout out. I had the opportunity to work with Phil for health. Oh God, boy, brain fog, I'm telling you. HCP Live on their network, which we actually talked about axial spondyloarthritis and naming it. So I'm going to reference that and some of the other talk show episodes we've done on this, because there was a whole session on it that another a tool, and I'm sorry, I just can't remember his last name because I call him a tool, another rheumatologist that did a session on the naming that I'm going to cover separately in a different debrief. But shout out to Phil, and we have no idea how to say it. There's a new oral therapy. So we think about oral. I know we all are now familiar with JAK inhibitors, which was kind of that first pill to come out. And then there's Otezla, which is also a pill form. And now we have oral tyrosine kinase inhibitor, but at the parentheses are TYK lowercase I. So we know when we see the JAK, it's JAK. It's a J, but I don't know how to say it. Anyone want to give it a shot? Tiki
sounds fun.
Tiki. Oh, that sounds very festive.
Yeah.
Seems like we should have a little drink with an umbrella.
A little tiki torch.
All right, I'll say tyke, just because we got a little. I don't know what the prize will be, but
yeah.
Okay.
So, and I'm leaning towards tyke, the type key with the.
You do tyke, I'll do tyke, and you do tiki. And we'll see if any of us.
All right.
Okay. Yeah. And that is by Bristol Myers Squibb. So we got to do a shout out. We love BMS. They have been huge supporters of our work. So this is a new drug that they have come out with to treat psoriatic arthritis. So very excited to hear more. I actually have a meeting with them in a few days. So they contacted me to have the meeting. So my guess is this is what they're going to talk about.
Yeah. Their new med. Yeah, exactly.
Yeah. So this one, and we've talked about, if you want to reference back to our debrief number 3, I go into more about what, and Katie, what the ACR20 and the ACR40, what all of that means, essentially the percentage of improvement. And this one had achievement of ACR up to ACR 70 at week 16.
That's impressive.
Significantly higher than the placebo. And when we say placebo, by the way, we're talking about when somebody in a trial does not know if they have the treatment or they don't have the treatment, and so they compare how somebody's doing, and the people, and it's blinded, so you don't know yourself if you have it or not, which we're going to cover in another session called placebo or nocebo. And nocebo is when your mind tricks you into thinking that you're going to have a poor outcome. So there's more. So stay tuned because it's exciting. Then we have GRAPPA, which is the Group for Research and Assessment on Psoriasis and Psoriatic Arthritis. Refined some psoriatic arthritis recommendations. So we want to give a shout out to GRAPPA. They have I can't remember which representative, but we have something called the Action Council that, stay tuned, is launching our first tool here in a couple weeks. And we do have a representative from GRAPPA. I don't want to say the wrong name because I don't have the list. I think I know who it is, but I just don't want to say the wrong name.
Yeah, right.
But anyway, so that they are represented on this council. But really, there were no real big changes. But what they did is they updated the research, and this ties directly into what we talked about in debrief number 3, which is, anybody want to mention? Do you know where I'm going with this? If you don't, I can continue.
I'm not following.
Okay. You're like, no. Okay,
yeah.
So we talked about the need for more research in order to then be able to choose those treatments with our doctors, because right now what happens a lot is treatments are given because of cost. I mean, it's cost saving. So as long as the data is there, as long as it's shown that if research is showing in clinical trials that something is working and something is efficacious and it's safe, there's no reason. I mean, and it's true, there is no reason for these governments or payers to ethically choose something different. I mean, they're saving money for the healthcare system. But as we start to document research and update these recommendations based on research, what'll end up happening is it's going to be hard for them to argue, well, this research is showing that treatment is actually better in certain patients than this treatment. And that's where it's policy and legislative and overstepping cost first, is then it flips. Then the ethical onus comes back to the doctor and the patient to work together, because the doctor is ethically obligated to treat the individual need of the patient. And if the research shows the individual, ding, there we go. So that's what I wanted to point out. That. So, yeah.
You want me to cover anything quickly? I've got about a few minutes before I have to leave.
Please,
to
go ahead. Yes, go ahead.
Was there anything in particular that you wanted me to
You said
mention?
you were going to mention something on juvenile arthritis.
Well, I've got a few things. So yeah, JIA, Juvenile Idiopathic Arthritis. One of the sessions I went to, it discovered that there were clusters. Patients treated with methotrexate, very common. They identified, I think it was 5, 6 different sort of clusters where they all reacted similarly based on different measurements. And then they tried that with Enbrel and discovered the same pattern was happening. So they're hoping that over the course of time, they can research that further and be able to develop even better treatments based on those clusters and how a patient would react. And then I think,
Katie, quick question. Did they specify whether the methotrexate was pill form or injection? Just curious.
Oh, no, I don't think they did, because I started on liquid methotrexate, but I didn't inject it, I drank it. So that's something I think I would have picked up on or noticed.
We can also look back. We can also look back at the research, because sometimes they don't mention that. But if you go and dig into the inclusion and the the methods of the study, that it'll highlight it. Sorry.
Yeah,
that's okay. And then there was another couple of things as far as JIA. One was, when you think of your ultimate goals, it's usually remission. But this was making the point that in musculoskeletal ultrasounds, the imaging could be more maybe beneficial as a end goal, as a target to achieve, rather than what you typically think of as clinical remission.
Oh,
okay. We're going to circle back to that point. I know you got to run, Katie. Katie is, she mentioned she is an employee of the organization, and she got to go to coalition call for biosimilars. So, all right, Katie.
Thank you. It's been fun, and I look forward to the next one.
Yes.
But don't you tune off, because Deb and I are going to finish this.
Yes.
So, all right. See you later, Katie.
Bye, Katie.
All right. So I'm going to just mention one other sentence to the GRAPPA that I thought was really important. And it's a quote. It says, "These recommendations, which include the most current data concerning the optimal assessment of therapeutic approaches to psoriatic arthritis, present contextual considerations that can empower shared decision making." So it's exactly what we're talking about. And again, our organization calls this research advocacy. I don't know if there are other organizations that have specific names for it, but that's what we call it. And that is research that is conducted that eventually can influence public policy. Even though it doesn't say public policy here, it can influence shared decision making. And that's the decision between the doctor and the patient. And when we talk about public policy, that's sort of where the missing gap is that it's not regardless, wherever you live, with the government or the step therapy or insurance companies, if there is a limit to access of these treatments, it is this type of research is what is going to be necessary in order to bring the conversation back and let the doctor decide. Oh, that was kind of a plug. Let the doctor decide. We're also part of that coalition led by ARDA, shut up, and the American Autoimmune Related Diseases Association, and I actually sit on the board of that that coalition. But that's all about what we're talking about here is letting patients and doctors decide. Deb, you sent me an email from ACR. We didn't have anything to report about new treatments in rheumatoid arthritis, but if you want to throw out what we saw, just, I mean, not cover it, just, well,
yeah, exactly. Just what it was. Again, yesterday they notified us. Again, ACR is later in the year, typically October, November, and they have new guidelines that they published. New RA recommendations. So they just did one last year, which surprised me. That's why I sent it.
Which we just said, right. It made it, we were complex, and they
exactly.
updated that they were complex.
Yeah.
So I guess that's something to tune in for later this year. There's more recommendations coming, but we were kind of like, oh, we're right in the middle of EULAR. We were kind of surprised to see that update that was coming at ACR 21. So there were a few treatment recommend. I don't know if recommendations, I shouldn't say that. There were a few treatment sessions for spondyloarthritis in particular, but I'm going to wait to bring those up because, as I've mentioned, I can't even remember if it was in this debrief, but we've done a couple of them today, so it's kind of running together. That I'm going to do a separate debrief on spondyloarthritis, not because I live with it per se, but because there was a session on naming and the whole non-radiographic versus radiographic, and that's a topic that we have been knee deep in for a couple of years. So it just kind of deserves its own separate, and I'll do that by myself, and I'll mention these in there. And then we had, I think that was it for the diseases. I did want to put though JIA, I'm going to swing back to juvenile arthritis, because this is really important based on some of the work we're doing at our organization. So the Juniper trial was I guess the pivotal data that led the FDA to approve Cosentyx, which is the medication I'm on, for use in kids with, oh, my phone's ringing. No, stop. Okay, sorry, real life here.
It is, yep.
So it was approved to use for juveniles, for kids with psoriatic arthritis. Oh, Katie's not on now. She had she said, I always say enthesitis, and she was saying enthesitis. So I'm saying enthesitis, but that is where you have the tendon inflammation, like in your heels and different areas, and that is attributed typically to spondyloarthritis diseases in general. I also have that. So I mean, and I'm on Cosentyx, so let's see. But anyway, it reduced flares by 72%. That's very good. And it also demonstrated superiority in the ACR counts, the ACR, which is the 2040 that we talked about in the past, and in disease activity at all. This was a study for 2 years, ages 2 through 18. I do not know the breakdown of those, but at the end of the treatment phase is 70. Oh, it was ACR 70.
Oh, there it is. Wow.
So that's really high. So that's saying a 70% improvement rate. So really impressive. And after drug withdrawal, which we've also talked about, 50% less flaring than those on placebo.
Wow.
So, and got to do a shout out. That's Novartis. And we also do collaborate with Novartis, and we are working. I literally have it over here on my desk.
Yeah, you just
working on some programming and information and understanding the missing gaps of juvenile arthritis, psoriatic juvenile arthritis, or enthesitis related JIA. And so if you are a person living with those, or you were diagnosed, you're an adult now, or anybody, definitely send them our way. You can send an email directly to me at Tiffany@AiArthritis.org, because I am leading that work. But that is with nephritis, so shout out. Then, so I wanted to just go back and mention that, and those are really as far as treatments. And then I want to just piggyback on what Katie started with the ultrasound in the technology. You actually brought this to my attention, Deb, with AiArthritis.
Yeah. She sent.
And tell who AiArthritis is first.
So AiArthritis is a rheumatologist in France, and she does some work with us on a project, and we'd work with her through OMERAC, but she actually specifically reached out to us. And you in particular first, because you were working a project with OMERAC, and she works with synovial tissue. And Tiffany's like, well, I know somebody who actually
who had a biopsy in her knee, and I had not had a biopsy in my knee. And the whole project, which you could also check out on our website, if you go to AiArthritis.org/research, you will find it. And we kind of tagged it in a talk show episode called "Changing the World with Your Knee." So if you want to learn more about that, go there. But that's AiArthritis, and we follow each other on Twitter, and Deb sends me a screenshot of something. And what is that?
Yeah, again, probably I sent you a couple of them, but this was a really interesting one. It's on new technology through that's happening in Germany, and they're using rheumatologists and computer scientists that are, working together to use artificial intelligence methods to analyze images of the hand. And it had these hands, and it had all the heat elements of like the red, yellow. So, red's like really hot, and the lighter parts of the blues. And it just was super interesting that they're looking at these images and trying to differentiate between psoriatic arthritis and rheumatoid arthritis, and analyzing the bony surfaces of the joint. And
apparently that makes a difference. And I did not know that you could visual, because I'm always really intrigued with how you can tell the difference of these types of arthritis on imaging. So I can't remember what she said. I don't know if you remember what her comment was on Twitter. I think I have it somewhere saved here.
I think I have it in our general bucket, because I threw it into the general bucket.
Yeah, I'm trying to find it. She had, here we are, Debrief, because she looked at it from a researcher perspective. Let's see if
she said hot is with, and then a fire next to it. Thermography of hands in inflammatory arthritis, and it talks about all the different features, and just it's really cool. And it also has the different scores that were related to
this is the point that I was going for. She questioned a future tool for patients in remote follow-up. And I was like, oh, that's interesting, because she's looking at it from the perspective of a rheumatologist and researcher. And of course, we're in e-health and at all times. And she led that. That's how, when we met her for the first time in person, I think was at EULAR in 2018
years ago.
And she was leading the e-health and so I can see why that question, that would be, wow, could we use this for patients to report? So I believe you could do it on your cell phone.
Could be.
I think I saw that on one of her tweets. Well, regardless, don't hold me to that. But my response back as a patient was, or to be believed, by everyone else that something's wrong with me.
Right.
Because if I could
Yeah.
take a picture, again, for whatever reason, I thought it said cell phone, but
It could, yeah. If we dig
I don't
deeper,
know.
yeah.
Don't
Yeah.
hold me to that. But I thought to myself, my God, if I could take an image at home with myself and show that something is going on in there,
Yeah.
when everybody
Shows
else doesn't think.
information.
And
Yeah.
that's, so as a patient, that's where my brain went to. So I just thought that was just an interesting point out why perspectives matter, and why there's so many different things that could come out of it. So as a rheumatologist, it was, wow, we could use this for e-health. As a patient, I was like, wow, people will believe me.
Yeah, exactly. Again, I mean, that's an ongoing theme that patients always have is, just to be believed by your rheumatologist that this isn't all in my head and I'm not making it up, et cetera, et cetera. There was the other post that I shared with you as well. Again, it was related to the shape of the second MCP joint. So the shape of your finger, and is that enough to train a neutral network with high accuracy of diagnosing RA and psoriatic arthritis? And she also had AUC. I'm not sure what AUC or HC is.
I'm not sure. We'll have to look that up.
Yeah,
We did start a glossary. We have started a glossary with all, so that those, we will be able to link and attach that as a resource, and it's ongoing. It's a living document, but have to add that, because I'm not sure off the top of my head. But anyway, notably, there was, we didn't go to a lot of the sessions that were on innovative technology, just because we figured we would learn like we did through Twitter, or but we can't see everything, and so that was just to note that they're working on it, and just as curiosity, I have to wonder if COVID triggered some of this innovation, because we all had to be clever, on how to do care. Deb, did you want to mention a few bullet points here about as we move into comorbidities?
Yeah, definitely. So there was one session that I was following pretty closely. It was rheumatoid arthritis, comorbidity, and clinical aspects. And I know we've talked about this, and this is, I believe, the third time we're bringing it up. But that one session on polypharmacy, is it associated with a power? Oh my goodness, I have to make that bigger. Sorry. Thought I would be able to read it, but that's with poorer treatment response and increased risk of adverse effects in early rheumatoid arthritis. So basically that was talking about, in their definition, polypharmacy means using 5 different drugs. But in the question answer, they also said that the pain medications, steroids, the DMARDs, the NSAIDs, those are all excluded from the medication list. So in their list, it's 5 drugs, but again, that's relating to their comorbidities, right? So whether you're on something for uveitis, or you're on something for your lungs, or whatever your comorbidity is, or cardiovascular disease, those type of things. So just bringing that back up, and in specific, their conclusions just came down to a couple bullets, and it just talked about that the polypharmacy is associated with increased disease activity, poor treatment response, and also the increased risk of other comorbidities. So, and they also said that there's a tight link between the polypharmacy and comorbidity burden. And they also said that, they're looking at a new measurement comorbidity tool for future reference. So again, that's all really interesting stuff as far as that goes, related to multiple medications for just the comorbidities. Because I mean, I know I've got a boatload of medications and most of them are specific to my own disease, but if I had multiple comorbidities, man, my medication
Yeah,
box would
I'm trying to
explode.
think. Well, I take well, I've always taken, well, not always, but for like last 30 years, 25
Uh-huh.
years, I've taken anxiety medication because that's just an order in my runs in my family.
Hmm.
So I take that, and I take for high blood pressure, but I'm hoping through diet and exercise, which I'm really dedicating. I'm really going to be focusing strongly on here very soon. Um, I'm hoping maybe that will level itself out. I wouldn't have to be
Yeah.
on it, but I think that it's it just kind of again, this is what happens. We do these
Yep.
debriefs, and then it triggers other things. Um, if you look back at this full the bigger picture of everything that we've been talking about in these debriefs, and there's got to be so much, all this research now on comorbidities. Not that there wasn't before, but
Right.
it's really clear, I think, when based on what's done with treat to target, or the in the 2000s, and that
Yep.
where they flipped the model we've talked about in other sessions, where it used to be diet, exercise, then treatments, and now it's treating early, and it's showing in research the remission. I think that probably also highlights that, and again, nobody said this is just, I'm just putting
Think it.
pieces
Yeah.
together, right? that if that highlighted that treating early before comorbidities essentially are present, because we're realizing the inflammation as the umbrella is
Right.
triggering the other stuff, right?
Right.
To go off and to
Right.
create, not necessarily high blood pressure, that's not from my disease, but like cardiovascular, or
Right.
lung issues, things that really are in
Yes.
a relationship to your disease, which is different than, we've talked about this, what is it, multi-morbidity, which is
Multi-morbidity.
patient in the center. That would be my high blood pressure. That would
Right.
be my anxiety. That is separate. That is not caused by my disease. Now,
Right.
it doesn't, like, some people, anxiety can go hand in hand, but there's a whole other story. Point being that if the research is showing that treat to target, basically before you have comorbidities that are a result of the uncontrolled inflammation, then it only makes sense logically that the research is going to move towards comorbidities, because they had to have recognized, okay, hold on. If we can achieve remission here, what are we going to do for the others?
Right. And again, it also shows the conclusion from ACR, we are complex.
Yeah. It's just that there's a storyline here,
Yeah.
and you can really, if you kind of sit back, and again, nobody laid this out, nobody
No.
did a session on it. This is just observation on, and I think it also, by setting that up, we kind of tee ourselves up to say, well, what is this going to do for patients and treatment plans in the future? So anything else that you wanted to
Yeah, there were a couple different sessions on, there was one on comorbidity on mortality in patients with rheumatoid arthritis. They were studying a group of folks from the 1980 to 2015, and this was done in Western Australia. And what it really came down to, their conclusions were, again, it's a very targeted group, but it said the annual comorbidity prevalence and mortality rates in Australia had decreased significantly since 2001. That's reflected improvements in management of RA and the comorbidities. So that was interesting.
Well, that's just exactly what we just said.
Yeah,
And
exactly.
once treat to target started, they
Yes.
saw the comorbidities go down.
Yes, and exactly. And they also, I know.
Look at that.
Yeah. So look there. We just talked about it, and there it is in research, plain as day.
Funny.
And they also said that the mortality rates in RA in that region remains 1.5 times higher than their community counterparts, just as far as other folks and stuff. And they said that there's definitely room for improvement to achieve further data as far as that goes. So that was an interesting, just more, because that mortality is something that always looms over folks
Right.
with these diagnoses. And
Well, and yeah, and a lot of people think, oh, rheumatoid arthritis, and they don't think about
no,
the seriousness of leading to
right.
death or other, but they don't think about what that uncontrolled inflammation leads to, and heart attacks, heart disease, and things of that nature. So
Right, right. And there were a couple other posters that were done on, you know, I believe, yeah, each one of them is rheumatoid arthritis patients with the comorbidity of cardiovascular disease. There were 3 different studies, and basically the outcomes, the study designs were all a little bit different, and they basically said the same thing, that RA, you are at a higher risk of developing different types of, like, whether it's heart failure or cardiovascular disease, you're definitely at a higher risk for that. There was one study, the last one was a 5-year cardiovascular event risk in early rheumatoid arthritis patients who received treat to target management, and it dealt with that particular population. So let me see if I can see. I believe he was from Hong Kong. Let me just double check. Yes. And the outcome basically came down to, so there were conclusions like a little bit more robust. So the longer remission duration was protective for cardiovascular events. So interesting. And it says in achieving a disease activity score of 28 remission may be good for cardiovascular protection. It said a higher disease activity at the first year may increase cardiovascular risk. So it says, is this the difficult to treat? So actually this might be another acronym, but it's one to add to our glossary. Capital D2 and then capital T, difficult to treat.
oh, look at that.
Yep, and that's again tied to things we've talked about already today. And it says RA are at a higher risk of cardiovascular disease, and that one doesn't necessarily, the last one doesn't necessarily apply, but the actual conclusions in layman's terms. So earlier diagnosis and treatment is huge. Tighter control, targeting at early remission, and the longer term is a sustainment of remission. So those are for early diagnosed folks, and versus people like me who, you know, I've been diagnosed for over 30 some odd years, and I've never had remission, and I don't think that's going to come. It's not in the books, but that's fine. But, you know, it doesn't help my risk.
As I look at myself again with these big pink cheeks.
Pink cheeks, yeah.
Oh.
It's doing you long day and flaring.
What's the difference?
Yeah.
Like
yeah.
white.
Yeah.
Okay. Sorry. That was not even I hope nobody does a screenshot. That was not an attractive face I was making right there. Okay. Anyway.
Yeah.
So
but yeah, just interesting information. And again, tying together with all of our themes that we've been talking about.
Yeah. And no, so last but not least, I'm not going to go in, and this is just like a mention, but there was one abstract that was presented for differences in real world patient characteristics. And it caught my eye because it was specifically, again, about, it mentioned that it says, right, quote unquote, due to the inclusion criteria of clinical trials, which limit patients that are representative of the real world in a clinical setting, registry data, meaning data banks, can complement any information gained about patient characteristics and disease outcomes that are not captured in a clinical trial. Which it's exactly what we've been talking about, that most of us can't be in clinical trials, and then you know, go back
They're
and
only
do the
using
other debriefs. We talked about this extensively earlier today, and then also in the debrief number 3. But this was for a real world assessing 8,921 psoriatic arthritis patients with and without comorbidities. And so the point of their research or their assessment was really to assess how many have psoriatic arthritis versus psoriasis, because there's typically a 10-year range onset, one or the other. I mean, you can have, which is so confusing to me, you can have psoriatic arthritis without psoriasis.
Yep.
It can come later, you know, or vice versa. You have the psoriasis and then later. So that's one of the things that they were studying, and then different comorbidities. But I wanted to point that out because we have also, as an organization, recognized this. I mean, when you're looking at research, again, when not being able to be included in clinical trials are the gold standard. So when medications are recommended or are chosen by your healthcare system, and they are citing credible research, safety, efficacy profiles in the gold standard, the clinical trial. However, there is, I guess the silver standard, if you will, is retroactive, or going, not using other data. So that could be, oh my God, the brain fog here. That could be post-market surveillance. That's what I was trying to say. Couldn't get it out. Where you're following patients, finding out how they are doing on treatments, and then assessing why are some responding different than others. So, that's a little bit different. And then you also have work in databases where you're asking questions, you're conducting research, you're collecting that information, and then you're doing kind of these cross references, if you will, to identify those subgroups or why. That is what we are literally doing. So we have a project called A Community Team, or ACT for short. It is an extension of an award-winning project from 2015, the original ACT project. And if you have psoriatic arthritis, rheumatoid arthritis, lupus, or axial spondyloarthritis, let us know. We are recruiting for it, and we're enrolling for it. It is an experience because it is an innovative project. So we'll give you details on getting involved in that, because I think it's a very exciting opportunity. But we are partnering with Forward National Data Bank for Rheumatic Diseases, shout out, who have graciously agreed and built and are housing our own AiArthritis data bank inside their servers. So we couldn't be more thankful. And that was a result of this Act 2 project. And they recognized, wow, what you all are doing is amazing. So we are literally, the things that were just talked about in this abstract is why we're working with them, and why we want all voices, all experiences, not just the ones who can do clinical trials, to be counted. So I just thought that was worth noting. And that's all I got.
It's gonna be a mic drop.
I disappeared. I got my screen.
All those people out there. Yeah,
all right,
I think
that's
we're
all I
all pretty
got.
brain dead. Yeah, we're all pretty brain dead.
Oh my gosh, I am literally, oh my gosh, it is 2:30 my time. I'm going to force myself to eat and take breaks, and I do have to watch some sessions for our next debrief tomorrow, which is going to cover patient collaboration and research. But that is so enjoyable, and I already just have so much knowledge in my head about it. I'm probably going to let you all lead it, and I can just fill in the blanks because, I'm excited. I'm excited to see them, but to see the sessions, but I will kind of, I think, lend everyone else a chance to have a voice on that. So that's it. We're signing off from debrief number 4 at EULAR 2021. We have a few more left to do. I think we're just over half, or about halfway through, and that's it. So thank you for tuning in, and we're going nap.
Yeah.
All right, see you all at the next debrief.
Okay.